Hello, today I will discuss about the myasthenia gravis. The myasthenia gravis is an autoimmune disease of the neuromuscular junction that affect the nicotinic receptors at the postsynaptic membrane. The effect of acetylcholine is decreased. Lack of neurotransmitter causes muscular weakness. So this is an axon terminal here. This is a motor neuron axon terminal here. And this is the skeletal muscle. And the disease is here in the neuromuscular junction. This is the postsynaptic membrane. And it has acetylcholine receptor. This acetylcholine receptor is blocked by antibodies. So these are the synaptic vesicles. These synaptic vesicles releases acetylcholine to the synaptic cleft, but this space is occupied by antibody. So the receptors for the acetylcholine cannot work here for acetylcholine. It is occupied by the antibody. So acetylcholine is released here, but acetylcholine has no action here. So there is no action potential in the muscle. There will be no muscle contraction. We need the acetylcholine from the synaptic vesicles that should go to the ligand gated nicotinic acetylcholine receptor in the neuromuscular junction postsynaptic membrane here, so that the sodium channel should get in, potassium channel should get out, and there should be action potential in the skeletal muscle. But in myasthenia gravis, as because the acetylcholine receptors are blocked, therefore no muscle action is taking place, so there is no action potential in the muscle, so there will be no muscle contraction, so there will be muscular weakness. This name is myasthenia gravis. That means the grave weakness of the muscles are not working, especially the skeletal muscle, because this is the neuromuscular junction. We are discussing the skeletal muscles. Okay. What is the epidemiology and demographic? Incidence is 2 to 5 cases in 1 million population. Female in their second to fourth decade. So in female, this disease is expressed, or it is manifested during the age 20 to 40 years. In male, it should be after the age of 60. So male to female ratio, usually female has more chance to get the disease, 3 is to 2. Okay. So again, this is the disease of the neuromuscular junction. The receptors are occupied by the antibody, that is the acetylcholine receptor antibody, and those antibody is occupying the receptors. So acetylcholine from the synaptic vesicle cannot work on that receptor, cannot touch on that receptor. There is no muscular action potential, no muscle contraction. Okay, that is the pathogenesis of the myasthenia gravis. Signs symptoms. This usually involve the muscles of the head and neck, muscles innervated by the cranial nerves. Okay, so muscle weakness worsen with exercise, improves on rest. Muscles weakness are fluctuating. So person has a good sleep, has a has rest, then they gain their muscle strength, because the receptor become unoccupied with that of the antibody for time being, so that acetylcholine can work there. Okay, so muscle weakness worsen with exercise or activity, and it improves on rest and sleep. Muscle weakness fluctuate, usually in the morning time patient has good muscle strength, As the day advances in the afternoon, after entire day work, they are exhausted and muscle weakness also increases. So at one time, their eyelid goes down, there will be ptosis or drooping of the eyelid. Their speech will be slurred speech, scanning speech, because the vocal cord will not work properly because muscular weakness. There will be weakness in the tongue muscle. There will be weakness in the muscles of facial expression. There will be weakness in the extraocular muscle. Person has diplopia of vision. Okay, so we got that. So extraocular muscle, like that of the superior oblique, inferior oblique, the lateral rectus, medial rectus, superior rectus, inferior rectus muscle, and levator palpebrae superioris muscle will be affected, that will not contract normally. So there will be extraocular muscle weakness. Tongue muscle problem, person cannot protrude tongue normally, okay, because of weakness of the muscle. And muscles of facial expression are also weak. Muscles of all facial expression will be weak in this person. There will be weakness of the muscles of the larynx, so there will be scanning speech. We discussed pharynx and esophagus has muscular weakness because those are supplied by the vagus nerve. So the cranial nerve will be affected, the bulbar nerve, the cranial nerve, the vagus nerve will be affected, so that person cannot swallow food, cannot speak properly. Okay, so that is the problem. And the diaphragm may be weakened, so that there may be respiratory distress. Diaphragm may be grossly malfunctional, especially in case of myasthenia gravis crisis. Okay, that may happen. We have multiple differential diagnosis. One is Lambert-Eaton syndrome, that happens in case of, this is a paraneoplastic syndrome that is associated with small cell lung cancer, botulism toxicity caused by a bacteria, that is the Clostridium botulinum. Okay, medication induced myasthenia gravis. There are multiple medication like aminoglycoside, like that of beta blockers, or the quinine anti-arrhythmic medication. A number of anti-cancer medication may cause myasthenia-like symptoms. Thyroid disorder. Thyroid is also caused in most cases by autoimmune mechanism. If we have one autoimmune mechanism, we may have another autoimmune mechanism. Myasthenia gravis is an autoimmune disorder. Hypothyroidism or hyperthyroidism are also autoimmune disorders. It is found that person with myasthenia gravis has more chance to get thyroid disorder. Guillain-Barré syndrome, that is a disease of the peripheral nervous system, ascending paralysis. There will be demyelination. Okay, Guillain-Barré syndrome have many causes, maybe due to vaccine, maybe due to some type of food poisoning. It may happen, so we'll get different type of history and different presentation. So, what are the workup to diagnose the case of myasthenia gravis? How can you diagnose? One test is called tensilon test. That is also called edrophonium test. Okay, that is an acetylcholine esterase inhibitor. If we give this intravenously, then person's symptoms, especially extraocular muscle symptom, people has drooping of the eyelid, that is ptosis. People has diplopia of vision, and muscles of facial expression are weak. So if you give edrophonium intravenously, it will work very quickly. Person will get relief from those muscular weakness, but it is short acting, and we usually do this test with that of the atropine to prevent cholinergic crisis. Okay. Repetitive nerve stimulation study. If we study the muscular contraction by nerve stimulation, it is usually the proximal muscle. Person has head and neck muscle. The proximal muscle, like that of the deltoid muscle, will be affected. Mostly that will be weak, but not the hand muscle, like that of the abductor digiti minimi muscle or the thinner muscles. That will not be affected too much. It is mostly the proximal muscle, like that of the deltoid muscle, trapezius. sternocleidomastoid muscle will be weaker. Okay. Serum acetylcholine receptor antibody. This is very important test. Around 80% cases, this is the antibody that work against the acetylcholine receptor that causes myasthenia gravis. Okay. We have other subset of patient. In those patients, this may not be found, but we may get mask antibody, muscle uptake tyrosine kinase antibody. So it is found in 15% cases. This is we need some muscle kinase to actually to develop the acetylcholine nicotinic receptor. So if there is an antibody there, then receptor will be broken down. It will not be arranged properly. So there will be myasthenia gravis. Another small subset of myasthenia gravis is lipotropin antibody study. That lipoprotein is also essential to produce or to maintain the postsynaptic nicotinic receptor, acetylcholine receptor. So antibody against it will also cause disturbed formation or non-formation or defective formation of the acetylcholine esterase receptors. Complement system may be activated due to antibody action on the acetylcholine nicotinic receptors. Chest X-ray and CT scan are essential to find out is there any type of thymus hyperplasia or thymus tumor. In both cases, it is those person with thymoma or thymic hyperplasia, they have more chance to get myasthenia gravis. That's why CT scan and chest X-ray may be required. Thyroid function test, we have discussed that the thyroid gland may be affected in a patient of myasthenia gravis, more chance to get thyroid disorder because this is also caused by many autoimmune conditions. Okay, it is also associated with autoimmune function. Spirometry to test the person's respiratory function. We do the spirometry so that lung function test is also done. Okay, so what are the therapeutics? This part should be done by the registered licensed physician. It should not be done by a non-licensed physician. We will give emphasis on the pharmacology part. Okay, it should be always consulted a by registered physician. So main line of therapy, first line of therapy is acetylcholine esterase inhibitor. That is the pyridostigmine. We have also neostigmine. Okay, that how it works. Actually, it will in this inhibitor. It will destroy or damage. It will destroy the acetylcholine esterase. So there will be more acetylcholine in the synaptic cleft that will attach to the nicotinic receptors. Okay, so to keep the acetylcholine in the synaptic cleft for a long time, this is the medication. Immunosuppression to decrease the load of antibodies. We have prednisolone, azathioprine, cyclosporine, all of them some adverse effect. And these drugs should be started with the doctor's supervision, nurse's supervision. Plasmapheresis is very important, especially in case of myasthenia gravis crisis. So we can remove the antibody from the body by means of plasmapheresis. Mechanical ventilation is essential again in case of myasthenia gravis crisis so that person can breathe nicely. Thymectomy, it is found that even the patient with myasthenia gravis without any hyperplasia of the thymus gland or no thymoma, if he or she has gone through thymectomy, a lot of patient has good benefit. So they may not have myasthenia syndrome. But we have to remember that myasthenia gravis has no cure. These are the way we can manage the patient. It will decrease the symptoms. Health education is very important so that we can prevent myasthenia gravis crisis. we can prevent cholinergic crisis. If we give too much medication, then there will be cholinergic crisis. Okay, and patients should avoid certain medication like that of beta blockers, aminoglycoside like that of gentamicin, kanamycin, streptomycin should be avoided as much as possible, and also some anti-arrhythmic drug like quinolone. So physician should always take care take care of this. So some medication may cause myasthenia syndrome. Okay, so the images I have taken from multiple resources for teaching purpose only. Okay, now we'll go to Viva question. What is myasthenia gravis? This is a disease, autoimmune disease that affect the nicotinic receptors in the postsynaptic membrane of the neuromuscular junction. What is the pathogenesis of myasthenia gravis? There is antibody, that is the acetylcholine receptor antibody that occupy the acetylcholine action site so that acetylcholine cannot work. What are the antibodies against nicotinic receptor in myasthenia gravis? That is acetylcholine receptor antibodies. We have other antibody that like that of the mask antibody and also the lipoprotein antibody. Their number is less. Most common is the acetylcholine receptor antibody. What is the epidemiology and demographic of myasthenia gravis? Mostly in the female in their second to fourth decade of their life, male after the sixth decade. What is the etiology of myasthenia gravis? That is the non-functioning of the postsynaptic acetylcholine receptors. What is myasthenia crisis? When a person with myasthenia gravis has some concurrent disease, then myasthenia symptom will be aggravated. Okay, what is cholinergic crisis? Due to too much medication, like that of the pyridostigmine, neostigmine too much, that may increase the amount of acetylcholine that will lead to acetylcholine esterase. That will lead to excessive acetylcholine that will lead to crisis. We can differentiate these two by means of adrophonium test or tensilon test. What are the different differential diagnosis of myasthenia gravis? Lambert-Eaton syndrome. We have the medication induced myasthenia gravis. We have also the botulinum toxicity. Okay, what are the diagnostic workup? Diagnostic workup, we should take the chest X-ray, CT scan. We must assess the acetylcholine receptor antibody, and if it is negative, then other antibodies. Okay, we do the thyroid function test, the lung function test by spirometry. Okay, and we we look for the muscle study. We give stimulation to the muscles, and especially the proximal muscle will be more weak. In case the muscle, it will be adjusted very quickly. It will be weaker due to muscle stimulation than that of the distal muscles. Okay, what is the treatment of myasthenia gravis? Again, acetylcholine esterase inhibitor. We have the treatment. We have the immunosuppression medication, thymectomy, another treatment, plasmapheresis, and supportive therapy like that of the oxygen and ventilation is required, and certainly health education.